Hello everyone, greetings from IJA. This is Dr. Karthik AR. Today I will be presenting an original article from the November issue of the Indian Journal of Anaesthesia. The article title is Predicting the Depth of Insertion of Central Venous Catheters Using a Bronchoscopy-based Carinal Measurement Technique or the Peary's Formula-based Method in Adults Undergoing Cardiac Surgery, a randomized comparative double-blind study. This study was conducted at All India Institute of Medical Sciences, Bhubaneswar, Odisha, in India. Introduction. Adequate depth of insertion of central venous catheters is critical to ensure appropriate treatment as well as prevent complications like vascular injury, cardiac tamponade, or atrial fibrillation. The carina on the preoperative chest X-ray is usually taken as the reference point for calculating the depth of insertion of central venous catheters. However, the carina may be poorly visualized on a preoperative chest X-ray. In addition, a preoperative chest X-ray may not be routinely indicated in many surgeries where a central venous catheter is indicated. Peary's formula-based method, that is height in centimeters by 10, is another method to estimate the depth of insertion of CVCs. Research question and objectives. They hypothesized that bronchoscopy-based carinal measurements would be more accurate in predicting the depth of insertion of CVCs compared to Peary's formula-based method. The primary objective of the study was to evaluate the difference in the proportion of correct CVC distal tip placements with both methods, bronchoscopy and Peary's formula method. Secondary objectives of the study were to determine whether the alignment of the central venous catheter distal tips in both groups and to compare the mean difference between the measured depth of insertion with the bronchoscopy method, the anatomical carina, and the measured depth of insertion with the chest X-ray method, the radiological carina. Institutional Ethical Committee approval was obtained and the trial was registered at the Clinical Trials Registry of India. Study design, it was a randomized comparative double-blind study in 81 participants. Inclusion criteria were adult patients more than 18 years of age of either gender undergoing cardiac surgery. Exclusion criteria, patients for whom a transesophageal echocardiography probe was not used or was unavailable at the time of assessment. Randomization was done in a 1:1 ratio. It was computer generated and concealed in sequentially numbered opaque envelopes. In both groups, the right internal jugular vein was cannulated using real-time ultrasound under sterile precautions with the patients in a 10 to 20 degrees Frenlenberg position. The transesophageal echo evaluations to determine the final position of the CVCs in both groups were carried out. Investigators who were blinded to the intervention groups and performed the DOI evaluations once the CVCs were inserted. Skin insertion reference point at the level of the cricoid cartilage lateral to the right carotid artery was marked using a skin marker pen. In the bronchoscopy group, a flexible adult bronchoscope was advanced into the tracheal tube and the carina was identified. When the bronchoscope's distal tip touched the carina, the operator grasped the proximal end of the scope just beyond the tracheal tube connector. The bronchoscope was then gently pulled out of the tracheal tube with the operator's finger still grasping the proximal end. The bronchoscope was cleaned and the total length from the grasped proximal point to the distal tip was measured with a scale, and this was measurement A. The distance from the angle of the mouth to the tracheal tube proximal end, to the tracheal tube connector proximal end, the angle of the mouth to the tracheal tube proximal end, where it connects with the right angle connector of the ventilator Y circuit was measured, and this distance was labeled as B. Finally, the distance from the reference point marked at the skin site at the cricoid cartilage level to the tracheal tube side facing the lower lip was measured with a right angle scale or a goniometer. This distance was labeled as C. The sum of these two distances, B and C, represented the length of the bronchoscope in the tracheal tube proximal to the cricoid. And this distance was subtracted from the measured total bronchoscopy length, A minus B plus C, to determine the measured depth of insertion of CVCs from the level of cricoid cartilage to the carina. After guide wire insertion, the distance between the point of guide wire insertion and the skin insertion reference point at the level of the cricoid cartilage was measured with a sterile scale. If the guide wire was inserted more cephalad to the marked reference point, this distance was added to the measured depth to determine the true insertion depth. If the guide wire was inserted more caudal to the reference point, then this distance was subtracted from the measured depth to determine the true depth. The central venous catheters were then inserted until the true depth of insertion. In the Peary's formula method group, the measured depth of insertion was calculated as height in centimeters by 10, with the reference point at the level of the cricoid cartilage. The distance between the measured depth of insertion and the point of guide wire insertion was similarly determined in the bronchoscopy group to give the true depth of insertion of the central venous catheters. The radiologically measured depth of insertion was correlated with the bronchoscopy measured depth of insertion in an additional cohort of patients who had a digital preoperative chest X-ray. Measurement of the carina to the medial border of the right sternoclavicular joint on the PAX with the PAX ruler was done. Measurement of the carina, this was the carina, to the medial border of the right sternoclavicular joint. This measurement was added to the surface measurement performed on the patient from the medial end of the bony prominence of the right sternoclavicular joint to the skin insertion reference point at the cricoid cartilage level to determine the depth of insertion using radiology. This was then correlated with the measured depth of insertion with bronchoscopy using the same skin insertion reference point. In both groups, central venous catheters distal tips were visualized with transesophageal echo in mid-esophageal bicaval view between 90 degrees to 110 degrees. The appropriate positioning of the CVC tips was considered to be the area from 2 centimeters above to 1 centimeter distal to the SVC right atrium junction, which was identified by the origin of the crista terminalis. The secondary outcomes were to assess the alignment of the CVC distal tips with the SVC wall and to correlate the measured depth of insertion with bronchoscopy versus chest X-ray. SPSS software version 21 was used for statistical analysis. Data were reported as mean standard deviation or proportions. Proportions of correct CVC placement and proportion of catheters abutting the SVC wall in the bronchoscopy and Peary's group were evaluated with the chi-square test. The differences in the mean depth of insertion of CVCs between the bronchoscopy and the Peary's methods were determined by the unpaired t-test. For all measures, P less than 0.05 two-tailed was taken as significant. This table shows the baseline characteristics between the bronchoscopy group and the Peary's method group. Age, weight, and height were comparable between both the groups, with more number of female patients in the Peary's group and most of the surgeries being valve replacements. Now, a more significant proportion of CVC tips were identified in the correct area in the bronchoscopy group, 36 out of 41, versus the Peary's group, 15 out of 40, with a p-value less than 0.05. In the bronchoscopy group, the CVC tips were identified at the SVC-RA junction in 7 patients versus 2 patients in the Peary's group. The CVCs had to be pulled out and repositioned in 2 patients in the bronchoscopy group and 8 patients in the Peary's group. This figure is a scatter plot, shows the distribution of the CVC distal tips in both groups. The dashed horizontal lines represent the correct target area for the appropriate depth of insertion of the CVCs. The 0 on the y-axis represents the SVC-RA junction. Negative numbers represent the distance in centimeters distal to the SVC-RA junction, and positive numbers represent the distance in centimeters above the SVC-RA junction. Now we can see in the Peary's group, there is more amount of insertions distal to the SVC-RA junction, and whereas in the bronchoscopy group, there are nearly equally distributed numbers in both sides, with more numbers being near the 0 line, which is the SVC-RA junction. A more significant proportion of CVC tips was found to be abutting the vessel wall in the Peary's group, as identified by a non-parallel alignment of the CVCs as well as the flow stream hitting the vessel wall. P less than 0.05. In the additional cohort, 16 patients in whom the correlation between the bronchoscopy and radiology measurements was found, the measured mean depth of insertion with the bronchoscopy method was 14.9 centimeters versus 13.3 centimeters with the chest X-ray method. They observed that CVC's distal tips were more correctly placed in the bronchoscopy group than in the Peary's group. In addition, the proportion of correctly aligned CVCs was higher in the bronchoscopy group. Their study also found a mean distance of 1.6 centimeters between the bronchoscopy and radiology measurements. This would imply that the anatomical carina likely corresponds to the SVC-RA junction. However, they agree that if chest X-ray is used to predict the depth of CVC insertion, a 1.5 to 1.6 centimeter safety margin should be added to the radiological measurements. The Peary's method in the study had a correct CVC distal tip placement of only 37.5%. There could be several reasons for this low success rate. This method does not take into account individualized needle insertion points. In Asian patients, the Peary's method had a success rate of only 49 to 52%. The study found a difference of 1 centimeter for the depth of insertion of CVCs between the bronchoscopy and the Peary's groups. Thus, they suggest that if the Peary's formula is used for CVC insertion through the right IJB route in Asian patients, 1 centimeter should be subtracted from the measured depth, height in centimeters by 10, with the reference needle insertion point at the level of the cricoid cartilage. The limitations of the study are that the results are valid only for CVC insertions through the right IJB route. They did not correlate the final measured depth of insertion with the actual depth of insertion in both groups to determine whether a significant correlation existed that would minimize the impact of different needle positions. Conclusion. So to conclude, bronchoscopy-based carinal measurement technique was superior to the Peary's formula-based method in predicting the depth of insertion of central venous catheters in right internal jugular vein in adults undergoing cardiac surgery. The authors have disclosed no conflicts of interest and no financial support for this study. Thank you.